Assalamualaikum warahmatullahi wabarakatuh, and very good morning, everyone. On behalf of Department of Emergency Medicine Hospital Chancellor Dr. Mukris, it is my great pleasure to welcome you all to the 8th Emergency Medicine Seminar Series. My name is Dr. Azhari, and I'm honored to be your moderator for today. So the 8th Emergency Medicine Seminar Series is proudly organized by Universiti Kebangsaan Malaysia, Universitas Brawijaya, and the University of the Philippines, co-organized by Toxicology Education Resources and Development, in collaboration with Southeast Asia Remote Envenomation Consultancy Services, College of Emergency Physicians Special Interest Group in Clinical Toxicology, Malaysian Society of Toxicology, Malaysian Society of Toxicology, Philippines Toxicology Society Incorporated, Toxicology Society of Indonesia, Wilderness and Austere Medicine Society, Pusat Racun Negara, and Malaysia Biodiversity Information System. A special appreciation goes to our valued sponsor, EMSTAT, Malaysian Society of Toxicology, Pusat Racun Negara, and finally, Southeast Asia Remote Envenomation Consultancy Services. Your generous support in making today's event possible are greatly appreciated. So today seminar marks week 1 of our 4 weeks seminar series, and today we'll be focusing on clinical and analytical toxicology. So the flow of today's seminar will be as follows. We will have 3 lecture sessions in the morning, and then after the lecture, we'll have Q&A forum sessions, followed by a Kahoot session at the end of the seminar. So do stay with us until the end, and it will be a great opportunity to review what we planned today. And of course, there will be an exciting prizes to be won. Before we begin, I'd like to share a few housekeeping reminders to ensure a smooth session. Number 1 is to kindly keep your microphone muted throughout the webinar. If you have any questions during the presentations, please post them in the Q&A or chat box. Your question will be answered during the Q&A sessions after the end of the third lecture. The session is being recorded, and the recording of the session will be made available later. Finally, for attendance, QR code will be shared on the screen at the end of this event. Kindly scan them and fill up the form for attendance. So without further delay, let's begin with our first speaker, Dr. Ruth Sabrina binti Safri. Dr. Sabrina is an emergency physician and clinical toxicologist based at the Emergency and Trauma Department, Hospital Raja Permaisuri Bangun, Ipoh. She has special interest in clinical toxicology and received advanced training at the Hong Kong Poison Information Center. She currently serves as the president of the Malaysian Society of Toxicology and is also a board member of the Asia Pacific Associations of Medical Toxicology, making her one of Malaysia's leading voices in clinical toxicology. Today, she will be sharing her talk entitled The Evolution of Analytical Toxicology in Malaysia, Transforming Poison Management Through Laboratory Innovation. Ladies and gentlemen, please join me in welcoming Dr. Sabrina. Dr. Sabrina.
Okay, Assalamualaikum and a very good morning to all of the participants of the first week of EMSS. So first of all, I would like to thank the organizing committee for actually inviting me to have some sort of sharing experience with regards to the topic that I will present for today. I hope the audio is okay and you can see my slides. So the topic that I chose for today as a sharing session is the evolution of analytical toxicology in Malaysia. A bit of actually change of the topic. I'll talk more of the optimizing poison management through laboratory investigation, a clinician-centred approach, because I believe that among us, there's a lot of clinicians and clinicians that actually managing real patients and not the one that is in the lab. So I think a clinician-centered approach is much more valuable for me to share the information with. Okay, right. So wait, yeah. At the end of the sharing session, so these are the 7 learning points that I hope you can carry home with you. So the first one is to determine the priorities of patient management. and knowing how to order smart rather than actually order everything under the sun when a poison patient comes to us. Number three is to know what is the clinical actionable test and what are the screening trap and the screening and interpretation importance to us, and also outlining a bit of clinical cases and what is the way forward for us in Malaysia. So in emergency department, as a healthcare provider, whether you are in the emergency department setting in klinik kesihatan or clinics, government clinics, or in the hospital, when a patient come, particularly when a poison patient comes or arrives in the ED, the first question that we want to ask is not of which machine should analyze this patient sample. It is rather than actually asking ourselves, is this really a poison patient? And if it is a poison patient, so I must actually do the stabilization, assessment and stabilization of the airway, breathing, circulation, disability, and also doing some sort of exposure. And determining the toxic syndrome or toxidromes and the evolving toxidromes is supposed to be the bread and butter for us, okay? And determining what can kill the patient first. So that's why the assessment of the ABCD is very important. And we cannot run away from resuscitation, toxidrome recognition, doing the bedside examination, investigation, and all these usually precedes the specialized toxicology testing. Analytical testing becomes valuable when it answers a specific clinical uncertainty. So that comes the question of what do I need to know now to make the next safe decision. So poisoning remains primarily a clinical diagnosis, and rarely we make a diagnosis of poisoning when the analytical components comes in. I mean, totally, it is totally rare. Usually, we have got some sorts of information starting from triage, but sometimes the history may be incomplete, delayed, misleading, or totally unavailable, especially when the patient comes in comatose position, comatose condition. Okay, so the toxidromes and physiological abnormalities provide the first diagnostic framework for us. And we should know that a normal or negative toxicology screen cannot actually overrule a convincing clinical syndrome. So our clinical assessment is number one. And if we have got laboratory confirmation, the laboratory confirmation should support and not to postpone the patient's stabilization and antidote delivery or treatment when it is indicated. So the point is to treat the patient first and to test with purpose. So where does analytical toxicology fit? Okay, so ideally, the laboratory investigation is most useful when the clinical question is clear. We know that when a patient comes to us, a focused targeted history and clinical assessment is the utmost importance, followed by our questions. What are the investigations that we want to send? From as simple as a bedside investigation, and also the things or biological sample that we want to test, that we want to send to the lab. And the thing is that choosing the right test at the right time and sending to the right laboratory is actually the most important thing for us to do. And after that, it's not really settled because once the test is actually comes back to us, we need to know how to interpret. If we are talking about TDM, we are fortunate as most of the tertiary hospital have the TDM pharmacies available for us to help us to interpret. But bear in mind, if let's say the information that we gave to the TDM pharmacies is actually kind of vague or unsure, so the interpretation can actually run off. Good interpretation will help us in making a clinical decision and also helping our patient to have a good outcome upon discharge. Yeah. So the thing is that 5 question clinicians want really laboratory to answer is that number one is the suspected toxicant is present when the poison patients come to us, and number two is the concentration clinically important for us because we know that um, some of the tests act as give the answer to us in terms of qualitative. Some of the tests actually give the answers or give the results in a quantitative. So which one is actually important to us? Is it quantitative, qualitative, or both? Okay. And number three, is there evidence of exposure when the history is uncertain? Okay. And number four is another toxicant or co-injection is present. And thus the whole toxicant thingy actually able to be detected by our laboratory test that we send to the lab. And number five, can the result change the treatment, the disposition of the patient, the prognosis, or public health action? Okay, so that's why a toxicology test is a clinical decision tool and not a fishing expedition where we throw all the baits that is available and hoping that actually the fish will take 1 or 2 baits. Okay, so will this test change what I do when we send the test to the lab? Will the test actually change what we are doing to the patient? The answer is certainly yes. But before ordering, define your decision as to how the result will influence your management. For example, does the results that you will actually receive will help you to determine whether you want to start or stop an antidote, whether you want to continue or whether you want to start the hemodialysis, whether you want to admit the patient to ICU for monitoring or admitting to psychiatry, or whether you will be helping the occupational or public health in terms of their investigation. Okay. And the value of a test will depend on the actionability as well as analytical accuracy that we provide. So ask ourselves, what will I do differently when the result returns? Okay. So there comes the ideal toxicology test. The ideal toxicology test is actually reflecting us sending clinically relevant analytes or biomarkers, and the test should be accurate and have a reproducible results if we are going to send the similar test to the other center, for example. And the test should have the turnaround time matched to the treatment window. Although it is easily said than done in certain testing, because certain testing does have a long turnaround time, but majority of the bedside investigation and also common TDM, for example, will have a reasonable, acceptable turnaround time for us to decide and manage the patient accurately. And then the other toxicology test also will have a clear, will definitely have a clear reference or decision threshold where a bit available. This is applicable for our pathologists, and also the accessible interpretation and direct laboratory clinician communication. This depends on center. In most of the tertiary hospital, the information regarding the interpretation of results, clinicians can always actually call our pathologists to actually communicate with regards to the best interest of the patient. So what we need now is the test that can be we can take action upon and accurate and also timely coming back to us for us to interpret. Time really matters. So we have got the result, and ideally the result should be within the clinical decision window that the physician wants to make. So typical timeline when a poison patient comes to us is that in time zero, if the patient is critically ill, we have to resuscitate the patients, and the bedside investigation should be completed within minutes when the patients comes to our red zone, including doing the ECGs, glucose, blood gases, and etc. And within 1 hour, when we send the routine, laboratory specimens, for example, the full blood count, the liver function test or renal function test, it should be available. And hours later is the drug level or the TDM. And specialized assay may take a bit longer. And days after is the test that we send to the reference lab. Okay, it can be months, it can be weeks or months lah. Especially if we are sending the specimens to the reference lab with regards to confirmatory testing. So a perfect answer that arrive after the treatment window may be clinically irrelevant. So this we have seen or in a few cases. Okay, for example, like managing toxic alcohol poisoning. But again, I think regarding to managing, for example, toxic alcohol poisoning, we don't need the confirmatory testing. However, we still need to send the specimens to the lab because it will actually affect of the occupational or public health actions that that will take actions to our notification. So we must actually alert that not every poison needs laboratory confirmation. So, for example, many envenomation and toxidromes are managed clinically. Okay, this is true. And in a patient, for example, who are actually coming for organophosphate poisoning, so we do not delay the atropine administration in a full-blown cholinergic crisis while waiting for our serum cholinesterase, right? Even the patients presented to the district hospital without specialists, they should be able to treat the patient without the level. However, if they are good, the medical officer may take the level and send it together with the patients to the tertiary hospital, and we can send it to the lab then. Okay, and the third one is do not delay supportive care for patients who are who took the sedative symptomatic agents or opioid toxicity. And also, specialized confirmation may still be useful later for diagnosis, surveillance, occupational exposure, or research. Okay, so sometimes the blood samples that we send to the lab, sometimes our pathologists do actually keep the samples in case that we need to test the specimens later on if issues arises. Okay, so the thing is that clinical urgency and analytical certainty are different priorities. When analytical confirmation becomes important, it is when the concentration determines the therapy or escalation. So I give example in paracetamol poisoning case. Okay, so we have to send the appropriate paracetamol level sample to the lab, stating whether it is a acute injection or repeated supratherapeutic or chronic or suspected massive, and then to take note about the time properly, informing the TDM pharmacist or the pharmacist on call, and hence actually you got the results within the TAT time, and the results will determine, will later help us in determining whether we should actually start the NAC if you send the TDM early, or whether you should actually stop the NAC if the level is undetectable, is below the treatment 9, or whether you should double the NAC therapy if the level is double the normal treatment 9. Okay, so this is the advancement. And number two, when analytical confirmation becomes important is that when the diagnosis is unclear and the result should really redirect our management. Okay. Number three is exposure that has delayed toxicity despite an initially well patient. So this is also important. Okay. And number four is when there is a narrow therapeutic index overdose, overdose of agent or potentially agent that is overdose can actually we can actually offer some sort of enhanced elimination. For example, in this point is the theophylline, acute theophylline overdose, where we know that theophylline have a narrow therapeutic index. So we should actually analyze the TDM and after that decide whether we should proceed with EE or not. Okay. And number 5 is when the incident happens in cluster, occupational, environmental, product, or public health implication. So in this kind of incidents, so analytical confirmations does becomes important. Okay. So we are talking about hi-fi testing, but we actually often overlook that the bedside and routine testing are analytical toxicology too. So don't disregard just as simple as testing your capillary blood glucose because it can actually give you a clue. Okay, and so does for the blood gases, the electrolyte levels, the RP and LFT, that often reveal a toxic physiology before the toxin is even identified because the toxicants take some time to be metabolized in our body. So the ECG, for example, is a rapid functional assay for, say, sodium channel blockade overdose or potassium channel effect overdose. Okay, and for the gaps, example are the osmolar gap and the anion gap. It can support the toxic alcohol assessment definitely, because we know that actually confirmatory test will take some time to arrive. So utilizing the gaps and also the gases would help really helpful in our patients management. And using the co-oximetry incorporated in our basic ABG testing, that detecting the carboxyhemoglobin and also methemoglobin may be useful to us, especially in some certain exposure of patient that comes to us. For example, in a fire victim, in a patient with unexplained hypoxia, for example, but the patient is still conscious. So this co-oximetry can help us a lot. Okay, start with our physiology and escalate to molecular identification when needed. Okay, molecular identification meaning that we want to send more investigation, more advanced testing to the confirmatory lab. Okay, so do not equate analytical toxicology only with mass spectrometry. Yeah, so there are few quantitative tests that directly guide our treatment. I can actually list down a few. So for example, as I mentioned before, the paracetamol concentration, it can help us in terms of risk assessment, revision, and the NAC decisions, the doses, whether we want to start with the normal doses, the double doses, or triple doses. And also the next quantitative test that I think is helpful for us is getting the salicylate concentration because with a serial measurement of the salicylate concentration, it can actually affect our next decision making, including deciding whether the patient will need some sort of hemodialysis or not. And the lithium concentration, because we know that actually lithium is a dialyzable drugs. In fact, actually a few days ago, we've got a patient who comes in from a psychiatric hospital who is on lithium but having a reduced conscious level. Of course, the medical officer there actually thinking of more towards towards organic brain disorder, sending to us for CT scan. But the CT scan appears normal. But at the same time, they are also broadening their mind and also differential diagnosis. They did send the lithium concentration from their side, and the lithium concentration turned out to be a toxic level. So after negative CT brain, we decide we want to proceed with the hemodialysis because it's already affecting the CNS of the patient. And after that, we are doing the level C ready to make sure that the concentration is literally less than 1 so that actually we can continue the monitoring and hold the dialysis. Okay. So number 4 is the digoxin concentration that might support the evidence of exposure. But again, if we want to send for the digoxin concentration, we must actually send in appropriate time Okay, and interpret the result carefully. And iron level, for example, quantitative iron level and selected therapeutic drug concentration can similarly guide in escalation of therapy. So a number matters only when interpreted with the time, appropriate time, in a exposed poison patient, and us knowing the toxicokinetics. Okay, so say example, a patient actually being exposed to paracetamol. This is the classic laboratory guided poisoning. We have got a lot of paracetamol flowchart guidance or protocol out there, especially from the US, from the UK, and from the Australia or New Zealand. Okay, so these are the things that we normally do, right? So we ask the patient when is the last time of injection, and then we send the TDM to the lab at the appropriate timing after discussing with our TDM pharmacist, and the TDM will measure the concentration, and after that interpret together with us, interpret with the clinical context and deciding whether NSC should be started, or NSC already started, should be continued or not. Okay, so the assay in this case is useful because a validated concentration time relationship informs the treatment. And again, sometimes we are dealing, we are asking somebody else to take the TDM, especially true for hospital that have medical officers and house officers kan. So we must emphasize to our junior doctors so that they actually take the TDM appropriately, meaning that if the TDM should be taken 2 hours later upon patient presentation, so it must be taken 2 hours later upon patient presentation and not actually taken when the patient comes in. This is in regards to the TDM PCM, for example, because if let's say people are taking everything together and assuming or sending the results, the test 2 hours later, but the blood is taken 2 hours earlier, it can create a false interpretation, maybe false reassurance, and leads to mismanagement of the patient. Okay. But then again, we know that paracetamol, the management is not only for acute overdose, we also have got repeated suprachaptic injection, delayed presentation, also massive overdose that requires a different clinical approach altogether. Okay, next is the toxic alcohols. When indirect laboratory clues save life, because we know that actually the confirmation will take some time, although some of the government hospital in Malaysia do have the serum alcohol concentration to be sent to. Maksudnya, we don't need to actually send to our makmal kesihatan awam kebangsaan in Sungai Buloh, or we don't need to send to Jabatan Kimia, okay? But then these are one or two laboratory in our government hospital that can do it. So how about those in Borneo? So that's the thing. The exact consultation may not be immediately available in most of the cases. So what we need is that a clinical context with the acid-base status interpretation, and utilizing the gaps, which is actually the osmol and also the anion gap, that can trigger early treatment. Okay, and gaps evolve with metabolism. And early exposure may have osmolar gap before marked acidosis. Okay. Do not wait for definitive confirmation when severe methanol or ethylene glycol poisoning is strongly suspected. Okay, so this is what I meant. When a patient comes to us, of course, the confirmatory testing is, we can send, but the result will not be available when we are treating the patient next. So we must utilize what we have, including properly analyzing the osmolar gap, calculate and measured, and also calculating the anion gap as well, because we know that the concentration, the osmolar gap and anion gap, quantity is different depending on what is the timing that the patient presented to us. Okay, right. Okay, the next one is cholinesterase, measurement of the cholinesterase level, and also pesticides poisoning. insecticide poisoning. So the diagnosis and initial entrepreneurization are clinical, and cholinesterase activities may support OP or carbapenem exposure, but it does not replace bedside assessment. So this is true lah. So severe results can assist exposure assessment, but if let's say you are correlating low cholinesterase level with severity, maksudnya for example low cholinesterase level equals to very severe patient. So the results actually varies. And specific pesticide identification is often more useful for confirmation, surveillance, occupational investigation, and research rather than actually immediate atropine dosing. So, for example, this is particularly true in Malaysia. Some of the center actually do identify the bottle of pesticide and sending or giving a maklum balas back to our Department of Agriculture for them to have some sort of data also of what are the patients that use what kind of insecticides that usually they will overdose themselves with. Okay, so these are the example of the insecticide cases that we have. The example of insecticide includes the majority that we usually receive. The case is called pyrifos and also the malathion component. Next one is carbon monoxide and also methemoglobinemia detection. When the patient comes to us with suspected carbon monoxide poisoning and also symptomatic methemoglobinemia, the pulse oximetry may be a misleading. Okay, we know that. And co-oximetry, if you have it, it will give a clinical actionable measurement of the carboxyhemoglobin and also methemoglobin level. But to interpret the level solely with numbers and not paying attention to the symptoms, the timing, whether the oxygen have already been administered to the patient is another context. So it's not about numbers. Other things and assessment need to be paying attention to. Okay. And the analytical results support the treatment, but severe clinical toxicity will remain the priority for us to treat the patient. UDT or UDS, urine drug skin. It is useful but dangerous when misunderstood. Most of the time, I usually will tell my junior doctors, sometimes we do the urine drug screen to actually comfort ourselves rather than actually to detect what's wrong with the patient. As long as we do the UDT, then we are okay with it. Sometimes we just want to document something and not taking actions to it. Okay, so most rapid screens, UDS, class-based immunoassay. Maksudnya, immunoassay testing as a POCT ni, the bottle that we have is actually the antibody. They are the antibody and it will detect the antigens in the class-based. So it is not a comprehensible toxicology analysis testing. The most important thing that we should know is that heavy cross-reactivity that can cause false positive results. So we must interpret it with careful interpretation, and many clinically important drugs and novel psychoactive substances nowadays may not be detected with our conventional UDS. So if we really suspect that the patient is actually overdose some sorts of actually drugs, but we cannot detect it, usually we will send for the confirmatory testing. So a positive results often indicates exposure most of the time, not really intoxication or causation, maybe, okay. So we must use it selectively. Screening is not equivalent to the diagnosis. And a negative toxicology screen does not exclude poisoning because we know that the agent may not be included in the panel. Okay, this is the panel, the usual panel that we have nowadays in Ministry of Health Malaysia Hospital Government. We have got a centered tender under our pathology, so whereby the hospital pathology department can buy either the 10 strip panel or the 5 strip panel. So these are the common one. We can actually pick whatever things that we want to put in the 10 panel, but this is the usual one. Psychiatric department may select certain urine drug panel for them to monitor, especially when they are monitoring an addiction patient and etc. So but with regards to the UDT again, the concentration may be below the assay cutoff point. So bila it is actually below the cutoff point, so it can't be detected. And pay attention to the sampling time. In acute patient comes to us very acute. You test the urine drug screen. Sometimes it may be too early, so it can't be detected, or too late. Okay. And the assay may target a metabolic rather than metabolites rather than the parent compound, or vice versa. So may not be a suitable testing. And the NPS and many natural toxins are commonly outside the routine panels. This we should know. So if you've got a negative screen, but you have got a strong convincing tox syndrome, so keep thinking whether this is still exposure to the drugs, but you need to send a confirmatory testing to the advanced lab, whereby a positive screen does not prove the toxicity, meaning that the detection can reflect therapeutic use or remote exposure. And urine detection windows may outlast clinical effect. Okay? And co-ingestion may be better explained the presentation of a positive or false positive results. So here, confirmatory testing may be needed when the answer has major clinical, occupational, or medical legal consequences. So most of the time, we cannot use the POCT urine drug screen in medical legal cases. It can help us with the clinical management, but certainly not in to be used in the medical legal cases. Yeah, for example, police wants us to actually test for the urine drug test. So what the police want is actually confirmatory testing. We take the sample and give to them so that they can actually bring the sample to the confirmatory lab. Okay, and reconcile the results with tox syndromes, ECG, physiology, and time course. Okay, so let's discuss about the patient now, the unknown poison patient. What should clinicians send them? So we know that actually when the patient comes to us, DRS ABC, D manage the patient, stabilize, and then comes to what are the investigation that we want to send. So if we are in blur, so we can actually discuss the case with our pathologist to see or to decide what are the best sample to send, and send appropriate specimens. This is actually the ideal situation before certain antidotes or procedures being done. But then again, without delaying care. If let's say you want to take urine, but you are delaying the care of the patient, so proceed first with the resuscitation and then actually send the specimens. Usually, the specimen that we will be sending is blood and urine. And special matrix specimens ni depends on the suspected toxins lah, macam gastric gastric content, vitreous humor content, etc. Okay, that is more towards the forensic component lah. And provide timing, the suspected agents that you suspect, the clinical syndrome or tox syndrome, the treatment that you have already given, and the key laboratory abnormalities that may present when you want to send the specimen. Yeah, I will say this. For example, if you want to send methanol sample, for example, so do provide this information, and retain additional specimens when the diagnosis is genuinely uncertain. This is truly, ini adalah tugas more of the pathology department lah. Okay, so specimen timing matters. A concentration without a time point can be uninterpretable. So we need to educate this again and again, remind ourselves and also remind our junior doctors. And the toxicokinetics change when the laboratory sees. So toxicants, when entering our body, so it undergoes the absorption, distribution, metabolism, and excretion, right? So it change what the laboratory sees, and some assays will require sampling after distribution and other need serial measurement most of the time. So if we are giving antidotes, doing hemodialysis, transfuse blood to the patient, and giving fluid therapy, sometimes it may alter the concentration a bit. Okay, and record exposure timing, sampling time, and treatment time. So in the bottom line, every toxicology sample should come with a clock. Okay, pre-analytical errors is real, but clinician can prevent this from happening. What are the types of pre-analytical errors that usually encounters is the wrong tube of preservative. Dah kena hantar baru kan. Okay, then insufficient volume or hemolyzed contaminated sample. Hemolyzed or contaminated samples. And another error that commonly we do is that no exposure or sampling time documented. Okay, and the specimen collected after major treatment without telling the laboratory. And poor storage or delayed transport. For example, again, I give the example of you want to send the serum ethanol and also serum methanol, or urine ethanol, urine methanol. So we must store it at the cold temperature and not at the room temperature, for example. Yeah, because if not, then it would change a bit the analysis later on. And some more, okay, sometimes in the form we just says that query poisoning without actually narrowing down what are your possible diagnoses. Okay, so that is some of the errors that we usually do that we can prevent. Okay. Bottom line is that sophisticated analysis cannot rescue a poor specimen and poor clinical history. So now, when do I need a GCMS or LCMS-MS or high resolution MS? Okay, so these are escalation tool. Okay, so not the first line resuscitation test. Nevertheless, in public health concerns, in certain poisoning cases, we will need this testing. Okay, so clinical question first, analytical platform second. Okay, just to outline lah. So for the confirmatory testing, usually we are using mass spectrometry, whether it's actually gas chromatography, liquid chromatography, or high resolution mass spectrometry. Yeah? So whereby GCMS usually analyze the volatile component with established libraries lah. Whereby the LCMS is actually sensitive to targeted panels. Most of the drugs and metabolites actually using this kind of machine, and it can quantify. And HRMS is really in the reference lab, whereby it can detect broad or untargeted screening. Bila kita guna ni, it can detect unexpected components. So that's why it's actually being useful. And it also can analyze retrospectively whatever things that we analyzed before with other machines. Okay. So comes to clinical cases. Case 1. Unconscious patient with unexplained tox syndrome. So you've got a middle-aged patient, coma, in intermittent agitation, with abnormal ECG, and history is unavailable. So what we should do, we should actually have our priorities. Again, the airway breathing circulation disability, utilize the bedside testing, and preliminary blood and urine investigation. The routine drug test screen is negative for this patient, but this does not end the diagnostic process. We usually will need to investigate further with regards to other form of differential diagnosis. And if, let's say, the other diagnosis or other investigation, including radio imaging, including LP, for example, is negative, so the course is going to be prolonged. So we may need to send the advanced screening to the lab. Usually, if we have got stored specimens, this is where it is important for us to send back the specimens to test further. The clinical value is that it can help us with the diagnosis, prognosis, counseling, surveillance, and also prevention of recurrence. So case 2, suspected pesticide poisoning. The patient presents with meiosis, bronchoria, the killer bees, fasciculation, nicotine component, and also after agricultural exposure. Most of the time, the agricultural exposure that we receive is still injection of the either insecticides or pesticides, insecticides or herbicides. Okay, so in suspected OP poisoning with cholinergic syndromes, we know that supportive care also emergency atropine therapy, we can begin it immediately on the clinical grounds. So cholinesterase level, if you have got the testing, it can support the exposure assessment, but should not delay treatment. And specific compound analysis may later clarify the pesticides, mixed exposures, or unexpected agent. For example, I've got a case with a clear-cut OP poisoning, comes in really drowning in their own secretions. So we instituted the appropriate treatment for OP. Usually for the liquid agent, we also sending the patient, sending the specimens of serum cholinesterase and also urine paraquat, which turned out to be the urine paraquat is also strongly positive. That means that the patient is having a mixed exposure of both insecticides and so herbicides. So this will really affect our management plan to the patient. And also the analytical results becomes especially valuable for occupational health, surveillance, and definitely prevention from happening again. So the third case is the natural toxins, marine, and also plant poisoning exposure. So Malaysia's biodiversity creates exposure that are poorly represented in routine toxicology panel. These examples include plant toxins, mushrooms, marine biotoxins, and venom-related biomarkers. Okay, most of the time in Malaysia lah, with regards to, for example, snakes, we may not actually need the SVDK or snake venom detection kit, for example, because for snake bite, the distinction between bitten by the Elapidae groups and also the Viperidae, we can some sorts of actually determining from the clinical and also the basic laboratory. But that is not really the case in our neighboring countries in the different region, in the different part of region of the world. Okay, for species identification, exposure history, and syndromic diagnosis is often remain central. This is applicable for all setting. And the reference standard and validated clinical assays are limited for many natural toxins. In fact, actually, with regards to this, we have just actually have a meeting discussing about guideline on poisonous fish and also marine biotoxin, whereby we are discussing whether there's a possibility for us to test qualitatively the certain natural toxins with regards to marine. For example, the tetrodotoxin and also, if I'm not mistaken, I've got another toxin that we discussed about that is feasible to be done by our reference lab. So just pray that we have got some development in the near future. And this is a major opportunity for clinician toxinologist chemist research collaboration. So what are the gaps between our Malaysia's clinical laboratory? So the things that specialized toxicology capability is concentrated rather than uniformly available. This is true. And clinicians may be uncertain of what tests exist and where to send the specimens and expected turnaround time because it is scattered. So clinician also is uncertain what to test, where to send, and expected TAT. And referral testing may return after the acute decision window, means that it comes back when the patient actually discharged or having a other outcome. And natural toxin, emerging drugs, and uncommon poisoning is really remain challenging, and clinical interpretation and lab expertise may sit in different institutions. For example, some of them are in the government hospital, some of them in the university hospital. This is a matter of time how we can collaborate all those services that we can utilize the most of the expertise. Yeah. So what should an ideal Malaysian service looks like? I think we have it already. We just need to jot it down and compile it somewhere so that we know where is the specimen that we can send. For example, level one is testing that we done, testing that we can do in the ED or hospital settings, whereby it is 24/7 available testing, including our blood gas, ECG, core symmetry, and also the common TDM levels that should be done or available in most ED. And if not, kalau katakan key drug level, for example, the TDM, most tertiary hospital should have it, or other minor hospital in the state should have it, yeah. Walaupun bukan semua. And then level 2, we are talking about regional hub where we can expand the targeted toxicology screening with using the CMS-MS capability and providing clinical consultation. And of course, the level 3 is including the national reference lab, whereby they offer the HRMS or rare toxins analysis and offer method development for new toxins and also act as a surveillance and research. We have it in Malaysia. So the national reference lab is including the MKAK in Sungai Buloh, and also in Borneo, if I'm not mistaken, there's also 102 lab, national reference lab, and also in other MKAK as well. And also we have got, not to forget the Jabatan Kimia, Chemistry Department. Although Jabatan Kimia is actually do the testing majoritarily for the medical legal cases, yeah. So it is ideal for one referral pathway, whereby we know the test menu, know the turnaround time, and somebody that can provide expert interpretation. Okay, so the one clinical pathway is including involvement of the clinicians and laboratory hospitals, and also reference laboratory, and also together with the poison center involvement for us to do appropriate toxicovigilance lah. So usually if there's a protocol, shared protocol or specimen collection and referral, this is actually the gold standard, and those that can provide direct discussion for high risk or diagnostically difficult cases is the ideal situation. So sometimes we do get this kind of consultation and results that return with interpretation support. Maksudnya the pathologist is also, especially the pathologists who are trained in toxicology, they can be able to inform the clinician about the interpretation of the results, okay, and to de-identify the analytical sickness that can actually be of impact to our occupational public health in terms of actually detection of clusters or emerging threat. Okay, so take home message is actually for us to do not ask only what toxicology tests that are available most of the time kan. So please ask what analytical information do I need to make the next clinical decision. And the future is not to have more testing, but it is a better integration of laboratory science with bedside toxicology and making what test that is in the book to be available to the user. Okay. So that's all. I would like to make some announcement regarding the 14th clinical toxicology course that will be conducted on the 19th to 20th October in Kota Kinabalu, Sabah. So you can actually scan the QR code if you're interested to know more or to learn more. Thank you.
Okay, thank you very much, Dr. Sabrina, for that compact and insightful lectures. Unfortunately, I was informed that Dr. Sabrina will not be able to join us during the Q&A session.
Yeah.
Okay, so because she has another professional commitment to attend to, on behalf of the organizing committee, we would like to sincerely thank Dr. Sabrina for taking the time to share her expertise and for excellent presentation this morning. And we wish you all the best, Dr. Sabrina. Thank you so much.
Okay. Thank you.
All right. If you have any questions specifically for Dr. Sabrina, please feel free to leave in the chat box. We'll do our best to compile and forward them to her after the seminar. Thank you, Dr. So let's continue with our second session. It is my great pleasure to introduce our second speaker, Dr. Kurniawan Taufiq from Dr. Saibul Regional General Hospital and the Faculty of Medicine, Universitas Brawijaya, Indonesia. Dr. Kadafi is a consultant pediatric emergency and intensive care specialist with extensive experience in pediatric emergency medicine, critical care, and disaster medicine. He currently serves as the head of disaster management task force of the Indonesian Pediatric Society and has contributed to numerous national and international initiatives in pediatric emergency care, disaster preparedness, and humanitarian medicines. His work has also taken him to several disaster response missions across Indonesia, reflecting his dedication to improving emergency care for children in challenging environments. So today, he will be sharing his expertise on the topic, clinical approach to pediatric poisoning, practical management in resource-limited setting. So without further ado, please join me in welcoming Dr. Kurniawan Taufiq Kadafi. Dr. Kadafi, the virtual floor is yours.
Okay, thank you. Assalamualaikum. Thank you for the MSS for the opportunity. Today, I would like to present my topic about the clinical approach to pediatric positioning, practical management in resources limited setting. This is the outline that we will discuss today. And first, I would like to discuss about the children vulnerability to positioning. Okay, why are children more vulnerable to positioning? Children receive more than toxin, come from the air, water, food, toxic chemical, household product, and heat. And before we discussing about the pediatric patienting, we must first understand one fundamental concept that children are not small adults. Children have higher metabolism rate, rapid organ development, immature detoxification, longer life expectancy, less body reserve and immune maturity. And this biological difference make them more susceptible to toxic exposure and more likely develop severe complication. This is why the pediatric positioning require a different clinical approach from the adult positioning. Compare with adults, children breathe more air, eat more food, drink more fluid per kilogram body weight. So consequently, they receive the proportionally higher dose of the environmental toxin. And another specific characteristic in children that more intake and less elimination. So children have the higher body burden. Another specific characteristic in children is about the development behavior. Behavior in children also play important role to make the higher risk of the positioning. Why? Because the children unable to recognize danger, hand-to-mouth behavior, have the natural curiosity and objective exploration. Because they cannot recognize the dangers, so sometimes the medication and household chemical can easily become accident patient in children. So in pediatric, curiosity is often a greatest risk factor to make the children high risk of the positioning. Why the toxin stay longer in child's body? Children not only receive more toxin, they also eliminate the toxins more slowly. Another problem is liver and kidney still developing. So it's make the children have the reduced metabolism, reduce the renal clearance, and the final consequence, there are the longer toxin exposure. And this condition as the parents, we have to be careful if the children will more contact with the toxin. The developing organ of the children are particularly sensitive to toxic injury, like the neurotoxin may affect the brain development and cognition. Air pollution uh, more stimulated the asthma and infection risk in children. Another problem, like the immune dysregulation, can stimulate increased infection risk. If the children contact with the carbon monoxide, so it can make the reduced oxygen carrying capacity. Another problem, like the heavy metal toxin that contact with children, can make the nephrotoxicity, and all of the toxins sometimes impact to the growth and development, hormonal and reproduction of the children. Most of the pediatric positioning occurs at home. Common source of the pediatric positioning include the medication, household cleaners, pesticide, kerosene, alcohol, and corrosive substance. And we, as the parents, have to keep hazardous substance out of fridge and out of salt. The pattern of the portioning changes with the age. For example, infants are mainly exposed to environmental contamination. Besides that, the toddler commonly experience accidental household portioning because curiosity. The different characteristic in the school age children are more often exposed to environmental chemical, and while the adolescent presents different challenges, including the intentional poisoning, substance abuse, and self-harm. Uh, Therefore, prevention strategy must be age-specific. In many hospitals, especially in the low resources setting like in our hospital, advanced toxicology laboratories sometimes are not immediately available. Therefore, management should never wait for the laboratory confirmation, like the Dr. Sabrina talked previously. Therefore, management should never wait laboratory examination the prior to stabilize of the patient using the ABCDE approach, obtain the focus of history, recognize the taxidrome, provide supportive care, and administer antidote if there are any indicated, and the clinical judgment is very important to us to make decision and to make the assessment to treat the patient. So to conclude this context about the children questioning, children are biological different from the adults, and they receive properly greater toxin exposure, eliminate toxins less efficient, more slowly, and have developing organ that are highly vulnerable to the injury. So the early clinical recognition and promote treatment safe lives is very important. In pediatric positioning, the clinical adjustment remain corner to successful management. And the next, I would like to discuss about our experience treat the patient with the suspected positioning. Case number 1, 14 years old female, 44 kilograms. The patient referred from the private hospital with a suspected generator gas intoxication. The patient was found weak, shivering, with a decreased consciousness during camping activity. She found at 1 p.m. inside a tent located approximately 1 meter from a running generator set that has been operating since 6 p.m. The exact time the patient entered the tent was unknown because the student have been instructed to rest at the 10 p.m. The patient later complained shortness of breath and chest pain. Previously, the patient suffered coughing 1 week before the admission, and the chest pain did not radiate, it was felt across the entire chest area. The shortness of breath progressively worsened, and the patient got a nausea, vomiting, and seizure at the previous hospital. There are the other history that 3 friends also experienced similar symptom. This is the clinical situation after the patient entered in our hospital. How about condition in emergency department? The patient was found irregular breathing, GCS 7, day saturation 77%, heart rate 154, irregular ECG, and with the increase of the white blood count and from the arterial blood gas, we got the patient a decrease of PO2 and desaturation. There are the increase of troponin A, EST increase too, and we stabilize the patient and analysis the ABCD airway pattern, and the patient developed apnea while the emergency department of the referral hospital. So we do the intubate in this patient, and no evidence of shock was observed, and the patient remained in the hemodynamic stable. The question is, can this case be definitively classified as the poisoning? If we think that this patient may be the poisoning, so we will analysis with the clinical situation in this patient. The child presented with the decrease of consciousness, general weakness, vomiting, shivering, progressively worsening dyspnea. And the first questions after we got the patient, was there possible exposure to toxic substance? In this case, one important clue was immediately identified as the patient had been camping near a generator set. This should raise immediately the red flag for us as a doctor for understanding that the exposure, this patient may be exposed to combustion product rather than infection as the primary explanation. And the next, is there an environmental clue? The scene is part of diagnosis. We know the generator set was operating near the tent, and the generator burned the gasoline. Carbon monoxide may be product from the generator, that we know the carbon monoxide is colorless, odorless, and the exposure can occur when the generator is positioned outdoors, particularly when exhaust accumulated near or enter an enclosed tent. Generally, the portable generator are well recognized source of the carbon monoxide poisoning in the main country. So this finding should raise suspicion for the carbon monoxide poisoning. And we know the environmental exposure to combustion product can be life-threatening even when the resources in the outdoors. The clinical presentation and exposure clue. Because in our center have the limited resources to check the substance of the poisoning or the toxin, so we analysis the cases by the exposure clue. The patient camping near a gasoline generator, the generator operating approximately 7 hours, the patient found consciousness inside the tent, and the specific characteristic, there are 3 friends of the patient develop similar symptom, but the symptoms more mild than the patient. The clinical presentation, the patient decreased level of consciousness, vomiting, progressive dyspnea, chest pain, and cardiorespiratory failure. And come from the laboratory finding and the clinical, this is the summary. There are the irregular breathing, so we intubate this patient, decrease consciousness, which is 7, desaturation with the room air, and after we intubate this patient, the saturation improve until 10%. There are the tachycardia in this patient, pale, cold, and lethargics. From the laboratory finding, we only got the leukocytosis. From the arterial blood gas, we got a decrease of the PO2 and desaturation. So the working diagnosis in this patient, carbon monoxide poisoning. We not only think about the carbon monoxide poisoning, but we also have to think about the other differential diagnosis. A toxicologist or the doctor should not stop after one possible diagnosis. We have to think another differential diagnosis. In this case, we have to think about the infectious infectious cases. Maybe the patient meningitis, encephalitis, or sepsis. And we have to think too about the metabolic causes like the hypoglycemia, but after we check, random blood glucose in this patient is normal, diabetic ketoacidosis. And because this patient adult, so adolescent, so we have to think about the neurological causes caused by the stroke maybe, or epilepsy. But from the history taking from this patient, we found history of seizure or epileptic treatment previously. And how about the toxicological causes? We think about the carbon monoxide intoxication, cyanide intoxication, alcohol intoxication, hydrocarbon intoxication, organophosphate intoxication. And based by the epidemiological clue, when the several individual at the same location develop similar symptom, a shared environmental exposure become much more likely. So in the setting, maybe carbon monoxide poisoning should move higher on the differential diagnosis. What investigation are required? The recommendation investigation including arterial or venous blood analysis to assess oxygenation, acid-base status, lactate maybe, and we maybe have to check the carboxyhemoglobin level to confirm test, lactate serum, electrocardiography in this patient in normal limit, no detection of the arrhythmia. There are the cardiac troponin in this patient. There are increase of the cardiac troponin, electrolyte in the normal limit in this patient, and the head CT scan to exclude the other possibility of the neurological abnormality. So the key confirmation of the laboratory test is carboxyhemoglobin using carboxy monoxide oximetry. What is the carboxyhemoglobin test is unavailable, like in our cases. The diagnosis can still be made clinically based by a credible exposure history, compatible symptom, environmental or epidemiological clue, and there are the history, similar illness among other exposure individual, and absence of a more alternative diagnosis. And the very important step after we diagnose this patient, treatment should not be delayed while waiting laboratory confirmation. The other question, does the patient fulfill diagnostic criteria for carbon monoxide poisoning? If we come back to the exposure history, there are the history generator near the 10. There are the symptom, decreased consciousness, vomiting, chest pain, deep snore. No alternative diagnosis. For the example metabolic, we exclude in these patients all of the marker of the metabolic in the normal limit. Before the patient decided join the camping, no sign of the infection in this patient, and traumatic causes excluded. And there are the evidence of tissue hypoxia like the hypoxemia, metabolic acidosis, and myocardial injury, So diagnosis high suggestive carbon monoxide poisoning, and we give the oxygen treatment in this patient. And according to the guideline, if the patient suspicions carbon monoxide poisoning and with the GCS below 8, like in our patient, the GCS is 7, with the pulmonary cardiovascular dysfunction, so the recommendation is intubate this patient. Our case, we decided to intubate patient and give the inspiratory oxygen fraction in the 100%. So why the patient developed respiratory failure and myocardial injury? If the patient inhaled the carbon monoxide, so there are the carboxyhemoglobin formation. There are the change of the binding between the hemoglobin and oxygen with the hemoglobin with the carbon monoxides. So it can make the oxygen capacity decrease, and there are the impairment of the oxygen delivery in this patient. What is the consequence? There are the tissue hypoxia, and it can stimulate the respiratory depression and metabolic acidosis. So it's the reason why the patient had the respiratory failure and need the mechanical ventilation. Another problem when the patient inhaled of the carbon monoxide. Hypoxia, myocardial hypoxia, with the signs of the myocardial hypoxia, the elevated of troponin, and it's make me have to be careful the cardiac arrest in this patient. And another condition, there are the myocardial dysfunction and oxidative stress. It can mix or stimulate the multi-organ effect. It is the theoretically that why the patient got the respiratory failure, because there are change of the binding in the normal, the hemoglobin will bind the oxygen, but in the carbon monoxide, there are the change of the binding because the carbon monoxide will bind the hemoglobin. And actually, after we observe the condition and we got why the patient very fast desaturation. In the first time the patient entered in the hospital, we got the conditions of the pneumonia in this patient because there are the history coughing 1 week before the patient admission in the hospital. And after we intubate this patient, there are the improvement of the chest X-ray and the clinically. And according to the theory, if a patient in the carbon monoxide poisoning, if a patient required intubation, the patient shall be ventilated with 100% oxygen. So, on 4 days in PICU during the treatment, every day we give in the higher inspiratory fraction of oxygen in 100% until the patient improvement, and we extubate the patient. Uh, After the patient from the mechanical ventilation, we follow the patient with the high flow nasal cannula with the flow 40, the inspiratory fraction oxygens only 40%. And this is the serial blood gas analysis. And the first time the patient enter in the hospital, there are the decrease of the PO2. It is the rare because sometimes we got a case with the carbon monoxide, the PO2 is still in the normal limit, but maybe in this patient previously got the respiratory tract infection, so it's simulated the decrease of the PO2 with the desaturation. After we intubate and we treat in 4 days in PICU, there are the improvement of PO2 and the oxygen saturation still stable. This condition, the patient condition, improve after we extubate and follow the high flow nasal cannula, and from the chest X-ray show the improvement. So the patient was extubated on the 6th day on the hospitalization. So we can got the message from these cases. We can learn this message. Sometimes we cannot definitively assess the patient in the carbon monoxide with the limited resources, because we uh, because the examination carboxy hemoglobins not available, so we can use the clinical finding, laboratory finding, and epidemiological clue to assess this patient. And after we treat the patient in standard carbon monoxide treatment, there are the improvement in this patient. Case number 2, 6-year-old boys, 20 kilogram. The patient presented with the odynophagia for 4 days before the patient hospitalization. The patient had been unable to eat for 1 week, experienced difficulty drinking, and had significant weight loss. Fever developed 3 days before admission, accompanied by the abdominal pain, nausea, vomiting after every meal. 2 weeks before admission, the patient accidentally ingested clear liquid that was later identified as the caustic soda, sodium hydroxide. Immediately after ingestions, the patient experienced burning sensation in the mouth and throat. There was no significant past medical history. There are the complex social history in this patient. The patient had been living in orphanage with his older sibling for the past 3 months because his mother has severe mental illness associated aggressive and abuse behavior. The father had left the family, and after the patient entered in the emergency ward, we got the patient in stable condition, GCS 15, heart rate in normal limit, no respiratory distress, the body temperature in the normal limit, and good oxygen saturation. This is the laboratory finding in the normal limit too. And from the abdominal X-ray, chest X-ray, cervical X-ray, is no significant abnormality. And we we done the esophagography, and the result is narrowing of middle and lower thoracic esophagus with the irregular mucosal contour, consists esophageal stricture associated the esophagitis, and we recheck with the cervicothoracal CT scan in this patient. And the conclusion of the CT scan, cervicothoracic CT scan, there are the multiple focal esophageal stricture with marked luminal stenosis involving cervical esophagus in C6 level and thoracic esophagus extended from T4 level to gastroesophageal junction. Associated with the finding included the esophagitis with erosive change extended into submucosal layer, secondary achalasia involving upper thoracic esophagus, no evidence of the thoracoesophageal fistula, esophageal perforation, abscess formation, or macellation. So, if we overview in this case, 6 years old accidentally drank a clear liquid that was actually caustic soda. The key problem, why did it happen to him? As the pediatrician, not only look the physical abnormality, but we have to observe about the growth and developmental problem in this patient. This is not only medical emergency, but also there are the social and safeguarding concerns. Why? Because there are the mental illness, maternal mental illness. The boy's mother has severe mental illness, so this condition maybe affect her ability to consistent care the patient, supervise the patient. So this situation increase risk accidentally injury. The boy's father left from the family, and it's maybe make the situation absence of the father figure can lead to emotional stress, reducing family support, and may impact the child's well-being. And the patient living in orphanage So maybe even though the patient living in the orphanage, but sometimes the children still risk if the supervisions and safety education are inadequate, like the patient. So the social determinants of health, this case show the how social factor can increase risk of the accidental poisoning in children. There are the several reasons because the parental mental illness, family disruption, inadequate supervision, unsafe storage chemical. So this factor together created a situation where child's vulnerable to exposure. Why this case interesting? I think this case is more than toxicology emergency, clinical toxicology emergency, but it's reflected that the cases is complex social background, high-risk environmental, vulnerable of the children, opportunity for prevention and child safeguarding if there are the intensive observation, intensive supervision for the parents or the caregiver. So after we analyze the social problem, we have to think what is the main toxin that can impact severity problem in this patient. Call this causatic soda poisoning. According to the exposure clue, there are the history, accidental ingestion of the clear liquid, and the latter identified as the sodium hydroxide. This make immediately burning sensation in the mouth and throat. And come from the clinical presentation, there are the odinophagia, dysphagia, unable to eat, difficult drinking, vomiting after meals, significant weight loss because inadequate intake in this patient, and chest discomfort. And why do this find suggestive to alkali injury? Because based by the esophagography and CT scan, there are the injury in esophagus, instead causing superficial coagulation caused by the alkali. There are the liquefaction necrosis, deep tissue perforation, progressive esophageal destruction, delay esophageal structure, and it is appropriate with the esophagography that in the patient there are the narrowing of the middle and lower thoracic esophagus. This occurs because the circumferential fibrosis make the luminal narrowing, and during the esophagography, luminal the barium difficult passing uh, through the lumen, and uh, this finding highly typical corrosive esophagitis. This is the condition, and come from the CT scan show the marked luminal stenosis. This means the fibrosis involves not only the mucosal but also reach submucosal and muscularized. And it's make the patient multifocal structure in the cervical and thoracic esophagus. Why the causatic soda make the multifocal structure? Because the causatic soda flow by gravity and alkali has high viscosity and long contact time with the patient, and this situation affect multiple esophageal segment. And we discussed the other theme, pediatric surgeon, pediatrician nutritionist decided to make adequate nutritional state by the gastrostomy. And the patient referred to the department otolaryngology for evaluation and management of the upper respiratory tract, uh, especially in the upper airway and pharyngeal, to identify the complication. And the team decided to make the esophageal dilatation using boogie dilators was attempt but failed to achieve adequate luminal aspiration. Therefore, the patient was scheduled to the esophageal replacement surgery. This is the step, our step treatment, gastrostomy. We consult the ENT and we use the Puggy dilator in this patient, but the results is not success. So the team decided to esophageal replacement surgery. Especially in pediatric positioning, the summary, we can understanding that children are not small adults that have higher metabolic rate, rapid organ development, immature detoxification, longer lives expectation, uh, less body reserve, biological difference, and there are the specific developmental behavior that its condition increase risk, like the natural curiosity, have the habit hand to mouth behavior, object explorations, unable to recognize dangers, and uh, during the children period, there are the developing organ that's more sensitive to the lot of the toxin, and sometimes the resources of the pediatric positioning come from at home, like the medication, household cleaner, pesticide. So if we didn't have a lot or the complete laboratory, or we stay in the limited resources, environmental clue matters, like the toxidrome. From the history taking, we identify the history of the process in this patient, so we can assess and decided to treat immediately, not wait the laboratory results. Thank you.
Okay, thank you very much, Dr. Kadafi, for that insightful lecture. We will see you again during our Q&A forum later, the third lecture. So, okay, again, to the participant, if you have any questions, please type them out in the chat box or the Q&A box, and we will have them answered during the forum later. Okay, ladies and gentlemen, we will now take a 15 minutes refreshment break. We'll resume the seminar at 10:20 a.m. So during the break, feel free to stretch, grab a cup of coffee and take a short break. But we kindly ask everyone to return on time so that we can continue with the program as scheduled. A gentle reminder as well, please stay with us until the end of the seminar. We still have an exciting final lecture, followed by an interactive Q&A sessions, and of course our Kahoot quiz, where you can stand a chance to win exciting prizes. So before we go, we would like to once again express our sincere appreciation to our valued sponsors, EMSTAT, Pusat Racun Negara, the Malaysian Society of Toxinology, and Southeast Asia Remote Envenomation Consultancy Services for their generous support for today's seminar. Thank you, everyone. We'll see you again at 10:20 a.m. Okay. Good morning once again, everyone, and welcome back. I hope you had a refreshing break and ready for our final session this morning. A gentle reminder to everyone that we'll have our panel discussion immediately after these presentations. So do continue posting your questions in the Q&A or chat box throughout these sessions. All right, so it's now my pleasure to introduce our final speaker for today's seminar, Dr. Ethel Joy Agaid. She is from the Region 2 Trauma and Medical Center, Philippines. Dr. Ethel is an emergency medicine consultant and clinical toxicologist. She completed her fellowship in clinical toxicology at the National Poison Management and Control Center of the Philippine General Hospital and currently serves as the designated toxicologist at Region 2 Trauma and Medical Center. In addition to her clinical work, Dr. Ethel has been actively involved in public health initiatives, community health programs, and humanitarian work across various regions of the Philippines. Her diverse experience has given her valuable insight into delivering emergency and toxicology care in a wide range of healthcare settings. So today, she will be sharing her talk entitled Analytical and Medical Toxicology in Resource-Limited Emergency Department, Making Critical Decisions when Toxicology Tests are not immediately available. So ladies and gentlemen, please join me in welcoming Dr. EJ. Dr. EJ, the virtual floor is yours.
Let me just share my slide. So I hope everyone can actually take a glimpse of my screen and of course for today's last lecture. And I actually have the privilege of being the last speaker just after the break. And the good news is that many of the key concepts and important principles have already been covered by our two previous excellent speakers. So we'll just go over them, highlight some focuses and reiterate key principles, a few practical pearls perhaps, and hopefully leave you with something new to take home after today's week. So here's what we're going through in the next 40 minutes. So objective 1 is actually the heart of this lecture, managing clinical poisoning and envenomation. Everything else serves that. And let me start by asking you a question about your own hospitals or your own institutions. So who among you here does have all these laboratory tests or perhaps these diagnostics materials in your own institution? And the next question perhaps that you would like to internalize is, what if there is no toxicology laboratory? Now, most of us actually, the honest answer is very few. If this, what you see in your screen does not exist at all. So actually, this is not a failure of our hospitals or nor your own institution. This is actually the normal condition of emergency practice across our regions. And I think let us be honest about what we actually have to or what we can work with during our hospital shifts. Okay, so the reality is that when you look at the left screen on what is in the left side of your screen, this is what we actually have. And on your right, it is what we actually wish you had. These are the things that we normally put in our procurement requests, but often than not, they are not being immediately granted or approved of. Now, in our experience here in the Philippines, many of the referrals when I was back in the fellowship training at the National Poison and Management Control Center of the UPPGH come from faraway provincial districts and primary healthcare centers where working with clinical assessment, basic laboratory, and basic diagnostic, and often than not, they just have an EKG and a glucometer and, of course, a phone call. And here, you can see in your right column, it says here venom assays. Now here in the Philippines, much so in where I practice in the Northern Luzon area, envenomation is actually managed clinically as well. And we'll come back to that later on. Now that brings us to the single most important idea in this lecture. As this was already introduced and shared by Dr. Sabrina a while ago and reinforced by Dr. Gaddafi, that analytical toxicology connects actually the patient. So you are sense of any formal training or a fellowship training at that. For example, you are in your hospital at 3 a.m. and you are the sole ED practitioner or even a generalist at that, you can be the medical toxicologist at 3 a.m. But the laboratory may or may not arrive, but you will always be at the patient by the bedside. However, these two does not compete with each other. Rather, the two are actually complementary. But then again, only one is always at the bedside, and you guys will be the one that always with the patient. Now, let's define those two halves properly because the distinction actually drives every decision that follows through in every case that we will be encountering. So when we talk about analytical toxicology, it actually answers what and how much. And right after that, on the other hand, medical or clinical toxicology answers what we emergency physicians in every case, whether it's a trauma case or it's a usual medical case or even a toxicology or a poison patient case, is that what do I do now? Now, from a clinician point of view, in a resource-limited emergency department, such that provincial districts and even primary care hospitals, the right column, this one, is always available, and the left one often is not. So, majority, if not always, clinical toxicology carries the load. Still, when the laboratory is available, it's actually worth knowing exactly what it can do for you or for us as clinicians. So, analytical toxicology is actually the science of identifying and measuring toxic substances in biological specimens. Now, the key line actually here is quantitation, not just detection. Of course, we need to detect because we need to identify toxicants, the toxic substances, or the poison involved. However, as much as detection is necessary or important for us to manage the patient as well, we also need to quantify because this will actually unlock specific therapies like does the patient need dialysis? Does the patient need antidotal therapy or even chelations? Now, on the other hand, these are some common specimens that we utilize or that we send to our analytical laboratories. Now, the blood, plasma, and even the serum are often used for quantitation, while that of the urine is actually for screening. Now, there are two simple mnemonics that captures why diagnostics and laboratory matters or why analytical toxicology is very complementary to medical toxicology. The first one is actually DIMPLE. Okay, so DIMPLE are the objectives. These are the aims of analytical toxicology. So we have diagnosis, identification, management, prognostication, law enforcement, that is medical, legal, and forensic research. However, for clinicians, department, frontliners, only these two are time critical at the bedside, diagnosing and management. The rest matters, however, they can unfold over time, hours, which we could not afford at times. And sometimes, like what was mentioned earlier, the identification itself and of course prognosis could actually days to weeks. Okay, now the companion to DIMPLE, or the aims of analytical toxicology, describes now what laboratory actually does, and that is promise. Okay, so the aims or objectives are DIMPLE, and the functions are what the laboratory can do or analytical toxicology can do is actually the promise. So we'll just be highlighting important functions here that may be very significant or relevant for us as frontliners in an emergency or in a resource or a limited resource setting. Now we have what we call monitoring. Of course, we cannot just diagnose, and every time we diagnose, we're going to give something, we're going to intervene. Now in that intervention or the treatment that we will be providing, very important is the monitoring. Why? Because it actually tells us if our treatment is actually working or not. And lastly, take a look at the last line. It says exclusion. Exclusion is that it's either a confirmation, much so as it was on the carbon monoxide, poison it as a something, it's a negative, it's a confident negative, or that rules out if intoxication or poisoning, and it is actually as valuable as someone or something that is positive, because often than not, as clinicians, we always look out for the confirmatory, no, or something that is positive. However, valuable as well as something that is negative or an exclusion. And of course, this would spare an admission of a certain patient, or perhaps a longer observation at the ED, ambulatory or observatory ward. Now, so how does a specimen actually become a result? There are actually three phases, and the instrument or the machine is rarely the weakest link. So this is the analytical workflow. This was actually brushed over by Dr. Sabrina a while ago. No? So we have the pre-analytical, the analytical, and the post-analytical. Now, most errors are actually yours and mine. So it's actually more on the pre-analytical doctors, not the machines. So what does that mean? We could actually use, or we put the specimen in a wrong tube, or we used the wrong specimen, we collected it at a wrong time, or it could be a number read without even a clinical context. So in the analytical workflow, in analytical toxicology, the two phases much so, the pre-analytical and the post-analytical are where we can control the quality. All right. So now let's take first the first phase, more and because it's the part that it's actually we can control, and it's part entirely in our hands. Now, there are two practical rules worth writing down, especially when we are selecting a specimen that we're going to send to the labs or to the anal lab. Now, take a note that fluoride oxalate tubes, you can actually ask that to your registrars, or our medical technologists can help us that. The things that we need to use if we are suspecting or if we're dealing with an ethanol or toxic alcohols like ethylene glycol. Otherwise, the level changes with the tube. So again, fluoride oxalate tubes. The next practical rule is that you always collect before you give any antidotal treatment or any antidote whenever it is feasible or wherever it is feasible. Okay, but I guess, and of course, realization will hit us that sometimes we forget to collect samples, or in our haste, in our desire to immediately treat the patient, we actually give medications or antidotal therapy, and then the labs comes in after. So wherever and whenever feasible, please collect before you give antidotal therapy. So confirmation could actually still be possible later. So, and it is suffice to emphasize as well that always record time since ingestion on the form. Okay, so in my humble practice, whenever we see or wherever we review our historical records, you will always say, or you can always actually see few hours. But for us in medical toxicology, we actually appreciate more if you will write down the exact time when the ingestion happened, because a lot of therapy or a lot of intervention will be determined from the time that the patient ingested to the time the patient presented at our ED. So this was actually mentioned and exemplified by Dr. Sabrina on paracetamol and the administration of an acetylcysteine. So recording time, you can actually just put in the time and then quantify or estimate of ingestion on ED presentation. Because, for example, on acetaminophen or in paracetamol level, without a time is uninterpretable on the Matthew or Rumac Matthew nomogram, or even so on the levels when you already have the results. Okay, so collect before antidotes where feasible, and if this is a medical legal or a forensic case, label and preserve and follow the chain of custody. And of course, do not forget timing versus ingestion chain. Once the specimen reaches now the diagnostic or the lab suite, there are two different kinds of tests, and confusing them is the most commonest error that we can actually encounter in toxicology. So this is screening versus confirmatory testing. Now, I would rather reiterate this, as it was actually best mentioned already by our previous two speakers, that a positive screen needs a confirmation, but a negative screen does not exclude poisoning. Okay, so the value of negativity or the value of a negative result and exclusion. However, experienced clinicians overtrust the screen and either both direction. So sometimes it can happen that we treat a false positive or discharge those on a false negative. So let us be reminded that, but confirmation now, toxicant or a certain toxic substance. Okay, so these two are complementary steps. But of course, it's not always the case. Sometimes for some higher institution, they could actually screen. And if you're one of the luckiest, you are more in the advanced or referral centers, you can actually confirm. But for us, in the far-flung regions, neither of the two are actually present. And what best actually to diagnose is always go back clinically. That is the toxidromal approach. Okay, now here are the actual tools behind these two columns, the one that we use in screening and the one that we use for confirmatory, for those of you who actually have these kinds of services. Okay, so these are our common analytical methods. Now, Immunoassays and color tests, just like TLCs or what we call a thin layer chromatography, are what a district laboratory realistically has, just like what was presented a while ago. They do have it in Malaysia, but not all. For the gas chromatography or the GCMS, and of course the liquid or the LCMS, or they are often in reference laboratory, tertiary hospitals, and they are often confined where the Center of Education business districts are confluenced too. So most in the cases, and in my area, we do not have these kinds of privilege. But in UV spectrophotometry is the quiet workhorse actually of paracetamol and salicylates. For those of you who actually have chemists in your medical or in your department, you can actually ask your chemist or the laboratory if they can actually form some of the UV spectrophotometry. Now, if you have none of those, as here, this is still real analytical toxicology that you can do with just a test tube or what you normally consider as a routine diagnostic or a routine laboratory tests. Okay, so I call it analytical toxicology in a budget, literal. Okay, so these are spot tests. This is taken from Gupta and of course from the WHO by Flanagan, which was published decades ago in 1995. So these are rapid color spot tests. Okay, so the WHO specifically wrote this manual precisely so hospital like ours, our limited resource and far-flung areas can actually or perform basic analytical toxicology. Now, there are two that may be change management. No, for example, the trinders for salicylate and the sodium dithionate for paraquat. Okay, for my case, here in the Region 2 Trauma Center, we do not have salicylates, trinders test, neither the sodium dithionate that can actually detect the urine. But mind you, we really have a lot of paraquat cases, and the mortality since 2019 up to now is actually 33%. That's actually a bit high for a country which actually banned the use of paraquat or dequat years ago. Okay, so in Thailand, they actually have this test. So good for Thailand. And if you have any plans to purchase or to procure, you might as well want to coordinate with Ramatiboti Poison Center. Okay, but whatever test you run, the result has still to be interpreted because a number is just a number, and it will not help us if it will not be interpreted on clinical context. And that's where things can actually go wrong because ED immunoassays often done not, 40% of which missed benzodiazepine diagnosis and 38% of amphetamines because interpretation is everything. And mind you, of course, this diagnostic has their own limitations already because interference may actually be giving us false positive, or then again, its sensitivity may lead us to something that are false negative. So this slide just tells us that we need to interpret every result against a reference range and do not forget the patient in front of you. So never one alone. Now that's just the laboratory science. Now, what can services it can actually offer us or offer you as clinicians? There are 8 services, not only detection and quantitation. For most of us here, present here, the first 4 are actually our daily business or our daily encounters in the emergency department. We deal about emergency toxicology. We do treatment efficacy, that is again one of the functions, serial monitoring, and the drugs of abuse and substances, detection and screening, and of course, do not forget the TDM or the therapeutic drug monitoring whenever you can. And this is actually beneficial for those who can actually access this service. Now, notwithstanding that the last four, this one, chemical incidents, forensic, medical legal, environmental and occupational, and of course, research, they do operate at the systems and public health level. And again, most of the time, we actually spend on the first floor or on the first four services of the diagnostic. Now, let's start where you live. All of us live in emergency toxicology at the emergency department. Okay, so this is actually the column that I would be asking you guys to put into heart, okay, or could be memorized or take a picture too, because these are actually the assays that could guide acute care, that could enable prompt management, and that would actually change what you do in the first few seconds, perhaps, if not the first few hours, because a specific antidote or elimination technique exists, just like for an acetylcysteine, for paracetamol, fomepizole, or IV or oral ethanol for toxic alcohols, and of course, chelation for iron and other heavy metals. Now, the right column confirms or refines, but rarely changes immediate plan. We can actually use them. We actually request them. But again, they can just confirm or refine further management or intervention. Okay, just like what we have been emphasizing since the very first treatment. Okay, we need not to identify the poison. We need not wait for the diagnostic for us to do something. But if you have the availability of this test, please make use of them. So if your hospital can stack or send only a few assays, argue for the left column. Okay, I've been always arguing for this for quite some time now in my own institution. But of course, it's not easy as it sounds because bureaucracy exists. Anyway, testing isn't only for the diagnostic, like detection, it's also for quantitation. It also tells us whether your treatment is monitoring or is it actually working. So going back to one of the promise function is actually monitoring. It will guide us and it will alarm us whether what we're doing is really working with the patient or not. Okay, so monitorings of drugs and drugs of abuse. So this, when we do special testing and of course serial testings and monitoring, the single number actually trends or trends out or it gives a trend. So the trend tells you whether what you're doing, whether it's a chelation or the dialysis or the CRTL that you're doing is actually working. However, there's a caveat here, especially with the drugs of abuse. Now, for the NPS or for the novel psychoactive substances, they are actually engineered to slip past immunoassays, and sometimes a negative screen in asymptomatic patients means very little. So if you will recall on a certain slide by Dr. Sabrina a while ago, even if the screen is negative but the patient is symptomatic, we'll still rely on what we're seeing with our clinical patients or with our judgment. Okay, so the chain of custody matters whenever result may end up in court. So please do not forget, especially when you are dealing with forensic or a legal case or a medical legal case. Now, this the same principle, the right sample, the right time now governs what we refer to as TDM. So the therapeutic drug monitoring or getting the dose right. So this is actually toxicology meeting everyday prescribing, especially when you have dealing with phenytoin, digoxin, vancomycin, and lithium, whether you're at the emergency or you're already working with patients at the ward or just seeing patients from time to time in your clinics. But the commonest pitfall actually here is the timing. What does it mean? When is the level drawn? So is it during the peak or is it during the trough? So a level drawn before a steady state or at a wrong point in a dosing interval is actually negligible or uninterpretable. So we just wasted money, we just wasted effort, and it's also one of we can say invasive every time we draw sample to the patient. Okay. However, these two services now that reach beyond the individual patient. So here, often than not, we have MCI involving a chemical incident and forensic. Pray to God, it does not involve a burn. No, so in a chemical incident, the emergency physician, you guys will always be the sentinel. You may be the first one to notice 3 patients from the same factory. So just a little bit of sharing. Way back in 2019 here in the Philippines, December at that. So we were having the Christmas party. And the Christmas or the Yuletide season, when I was still a resident, and for those of you from the Philippines, maybe you share the same experiences. We receive a patient who actually was unresponsive. We initiated BLS and then ACLS. So we were actually able to revive the patient. Now the history actually says that the patient was severely intoxicated. Just that. Okay, so the labs came in. So the labs actually does not justify the clinical picture of the patient. So we were really at loss because limited information from the group of friends who brought him were available. And then an hour or two, another patient comes in. Okay, and then it became 6. That's just in our institution. Okay, so after 4 hours, we actually learned that these patients came from the same or almost neighboring provinces in the southern area of the Philippines or the southern Luzon, where lambanog, we call it a lambanog. No? So that's actually alcohol. No? So it's taken from a coconut. So it's a byproduct when it is too much is actually methanol. So a lot of cases, and this has been gone through for other hospitals as well. No? So in UPPGH, they actually receive 92 patients at the peak of during that 1 week. So we had a methanol scare or methanol incidents during the 2019. And mind you, we do not have the methanol, the zero methanol capacity, but of course, we have what we call investigational or laboratory that clues that could indirectly give us that this could be toxic alcohol. Okay. So this is briefly the list, ED facings, no, services, and this biomarkers and exposure. It just answers 3 questions. 3 biomarkers, 3 questions. How much got in? What has it done? And who is at most at risk? So for the reference value, this is something that we could actually use in occupational health decisions. Okay. So now let's go back to the bedside where most of you actually spend your shifts. Okay, so we've spent, more than 20 minutes on laboratory or analytical toxicology. Everything from here is what you do now without it, precisely because that is the thesis of this lecture. Now, there are 3 pillars. History, you have your examination and your clinical evidence, and never a single observation. I cannot overemphasize what you do on monitoring and serial monitoring and even serial testing. Now, on the dark strip below is actually the key point in this slide. Stabilize and prevent absorption before any confirmatory results return. So that's what we call often, or that's what we always emphasize in emergency stabilization during a toxicologic case. No, before you can actually identify or before you can diagnose it's actually a poisoning or envenoming, you need to stabilize and of course do something to prevent further harm by preventing absorption. Now the lab actually supports resuscitation. It never gates it. Okay, and that is something that we need really to embed in our practice. So what can you read off the patient in the first 60 seconds? So when you have a minute or two, what can you do? So bedside clues to the poison. Okay, so always and always in every toxicologic lecture, toxinology lecture, or any webinar series, conference that you will be attending, you will always see or receive something bedside clues, and we do call them at attributes or better known as toxidrome. Observation returns. We'll go back to training. We are taught that we see patient, we palpate, we feel, no, with our hands, and we hear. Okay, but of course here we're adding another sense, used odors or your sense of smell. Okay, so these assays are actually free assays. I can call them free assays. You need not to pay for it, no, to smell, to look at the pupils. So they are available even before any results comes in. So we have the classics here, and I'm sure you guys are all familiar with it, like the bitter almonds. It may be something pertaining to a cyanide or the garlic breath, or organophosphates, or poisoning, the rotten eggs, the H2S. And of course, when you have the wet lungs, you have cholinergic, and the opposite to that, when someone is very dry up, we have the cholinergics. Okay, but the safety caveat of this never excludes the poison. Many patients don't actually read the textbook. Okay, so again, we are going to use our clinical assessment history and of course their exposures, as what mentioned by Dr. Gaddafi a while ago. So alongside the examination, there are a handful of tests that are genuinely toxicology tests. So if you will take a look on many medical drama, they would actually say, or run the tox panel. Is the tox panel result or is the tox lab already available? Okay, but these are actually not just routine tests. Okay, others may call it routine, but they are actually toxicological tests. So the next time you might want to ask, or they might want to refer to a toxicology test, okay, you might want to include the following, because these are actually what changes management. And every ED, if you still not have this, but I'm pretty sure majority actually have this, and they are often out-informed a tox screen. So you have an EKG. If you don't have an EKG, you actually have your cardiac monitors, and we cannot overemphasize the importance of having a glucometer because this to diagnose more poisonings in the first seconds rather than any send out assays. Okay, so just these two, EKG and you have your glucometer. Okay, because they will already tell us a lot of indirect clues of what a poison patient might be or might have had. Right, so here we have on the EKG, for example, you have a sodium channel blockade like your TCAs, or perhaps you'll have your anticholinergics here, hyperkalemia, and QT prolongations. Most often than not, these are antipsychotics, medications, ODs. And of course, I would like to encourage everyone that teen bloods, okay, we need now to consider them as toxicology tests. So apart from these two, you have your blood gases, right? And then your electrolytes, including your anion gap, no, and or your gaps, your creatinine. These are very good indicators on what you're going to do next, and of course, prognosticate the patient. And please do not forget your liver functions and your CKs as well. No, so again, I'm encouraging everybody to stop calling this routine bloods or routine diagnostics. Rather than let's treat them from now on toxicology tests. So now that this test you wish you'll have, and what to do about it. Sorry. Okay, so these are often useful, but well, nonetheless, they are often not available, or it can be um, distant to us or not immediately accessible. So these are very useful but frequently available. Now, these are category 2, and category 3 rarely changes the first hour. So now here, it's very important to know your referral pathway, especially for those among you who are working in a primary healthcare setting or in a district hospital, so that, or how can you reach your reference or your toxicology specialty centers, whether you need just to transfer the patient for confirmatory testing. Now, the question will lie, is it worth it? The travel, time, and of course, the stress, while you can, in fact, manage the patient initially with them guided. So again, this can be, these are very useful but often unavailable, especially acetaminophen, salicylate, digoxin. You have your AEDs, no, anti-epileptic drugs, lithium, and iron. So whether or not the level arrives in your cases, the principles of treatment never changes. Okay, so these are just some applications I hope in any farming or agricultural community, like most of us in Southeast Asia, we do have a lot of carbamate and OPs. And here in our region or in our institution particularly, we cannot afford, or we do not have the RBC cholinesterase. But in UPPGH, it is actually available. And in the southernmost region of the Philippines, in Zamboanga, they actually have something like this. So we do rely clinically. Does the patient displays the what we call cholinergic syndrome? No. So does the patient have the killer bees, the bronchuria, bradycardia? Does the patient presents with meiosis or sludge? And sometimes we ask them if they could possibly bring the toxicant or the source of the poisoning. If not, just take a picture so that it can somehow help us identify and confirm that this is really indeed the poison that the patient was exposed to. Okay, so here you have what the action needed. You have your physiologic antidote, atropine, titrated to clinical endpoints. You have to dry out the secretions. In some of the books, it says 80 to 100. In some, it says actually that it's more than 60 to reach the heart rate. Okay, so this is what we have discussed a while ago, the case 2 methanol that took place here in the Philippines about in 2019, 5 years ago. We do not have the serum methanol level, but we diagnose it, especially on the visual symptoms and the acid-based pattern. And then, of course, we need to treat the patient first fast, because as time elapses, the degree and severity of the symptomatology and, of course, the prognosis worsens. So treat first and confirm later. But here in this case, a normal osmolar gap does not exclude toxic alcohol once metabolism has begun. All right. So there are more cases that we can actually do without much of the analytical diagnostic or even a little diagnostic. And unfortunately for us, where I came from or where I am currently working with, none of these are actually present in my laboratory, except for the initial tox labs like ABGs, EKGs, and glucometers, and of course the blood works. Now there are 2 more And like I said, aside from pesticide poisoning, I do receive a lot of insecticides, just like paraquat. Yes, it is banned. For some of you, like in India, Sri Lanka, they may be experiencing a diquat, but for us, it's actually paraquat. Paraquat is a very effective insecticide. So despite it being banned, a lot of our farmers are actually still using it because it's very cost effective. So in paraquat, this is a patient of mine last May. So in paraquat, exposure history is very important in the presence of oral ulceration. And as you can see, they will actually present with AKI and sometimes pulmonary distress, developing to pulmonary fibrosis. Unfortunately, again, we do not have the urine dithionite tests in our institution. Much so, it's not available. As far as I'm knowledgeable of, it's not available in the Philippines yet. So here, what we can do is that early decontamination actually decides the outcome. And urine dithionite, if available, because it will actually tell us if it's a paraquat or diquat. Okay? Now, going back to another case is actually snake envenoming or snake bite envenomation. Okay. We have one of the most deadly, if not, that one of the deadliest snakes in the Philippines is the northern Luzon cobra. We have the Naha philippinensis, which fortunately we have the anti-venin or anti-venom. But to determine actually if that is really the Naha philippinensis or what species that we do not have the assay. So we rely still with physical identification. What they do normally is that if I do not actually encourage you to do that, okay, for safety's purposes, and it's kind of difficult or to really establish the identification just by merely the picture. And aside from neurotoxic snakes, we also have hematoxic snakes, pit viper, Philippine pit vipers in the northern region area. And again, since we do not have the AC, we go back to our most accessible bedside test, which is the 20-minute whole blood clotting test. And we often actually advise our primary care practitioners to do this prior or during their referral if coagulative testing is not available in their institution. Okay, so this is toxinology, at bedside. So those cases, 4 cases, 1 pattern. Now here's how to make it reproducible in your next shift. I call it the 5H. Okay, this is just a practical framework. So if you remember one framework, make it this one, at least with regards to my lecture. And I cannot overemphasize the value or the importance of history, as it is one of the highest yield investigation in all of the toxicology. Okay, so here we especially take a look or explore the agent, the dose, the timing of the investigation, the route, and the co-exposures. So when investigating toxic patients or poisoning or envenoming patients, exposures is very important because it will actually help us also in the diagnosis and identification, right? And heart, why is it hard? Okay, always obtain an EKG and help. Okay, help. So you have know when to refer and know when to transfer. Okay, so know when your poison center numbers, and your referral threshold before you need to call them. Like, do I need to already refer this patient, or at this point in time, is there something that I can do prior to referring or prior to recalling? And by the way, do you know your poison center numbers by heart? It's actually very helpful, in times that we are having some difficulty dealing with envenoming or poison patients. So today might be a good time to save it or to refresh our memory a bit. Now, which now raises the bigger picture. How do we strengthen this across the Asian region, or if not in Southeast Asian region? Because as we maintain, we are locally grounded but globally minded in our theme in this EMSS 2026. Here we need to have a local clinical skill, and of course, that's why we're here to build some opportunities for regional network. So these are just some levers or some leverage that we can do. Regional teletoxicology, shared reference laboratories among Asians and point of care testings, and regional toxicovigilance. Okay, so maybe as you go along or as you recall back together with the two previous lectures, you can actually name one gap in your own institution or in your own hospital, no? And that gap could the start or the trigger where your collaboration starts. Now, let me leave you with 5 things to carry out in your next shifts, and it could be actually our take-home message as well. And if you remember one line, and I cannot overemphasize this as it was mentioned by our 2 excellent speakers a while ago, make it the first. Treat the patient, not the laboratory results. Okay. And then basic investigation often provide enough information for life-saving decisions. Those the things that we call routine bloods, they actually are part of a toxicology laboratory. And a positive screen needs confirmation if you can or if it's available. But a negative screen, the idea or the function of exclusion does not exclude poisoning, and an absent confirmatory testing should not delay antidotal or antivenin therapy when poisoning or envenoming is actually strongly suspected. So the best toxicologic care is possible in a low resource EDs. Okay, as you might have seen, we have a lot of success stories, just like what was presented by Dr. Gaddafi a while ago on his 2 patients. No, despite having limited resources as well, they were able actually to lift these 2 pediatric patients from the doldrum of a poor prognosis and further deterioration. And one final thought for this morning, the best toxicology laboratory in a resource-limited emergency department is still a well-trained emergency physician armed with sound clinical judgment. That's why we conduct such sessions for us to become aware, more knowledgeable, despite us not having a formal toxicological or toxicological training at that. Now, I would like to thank the Department of Emergency Medicine, Hospital Chancellor, Tunku Muris, and University Kebangsaan Malaysia, and the EAMS 2026 organizers. Thank you again, and good morning.
Okay, thank you so much, Dr. EJ, for that comprehensive lectures. Ladies and gentlemen, we have now come to the end of our seminar. Thank you everyone who have been actively submitting questions, and we will proceed to our Q&A sessions in a short while. Again, if anyone have any questions, please drop them up in the chat box. We will have them answered later. Also, don't leave the seminar yet, because after this we have a group session after this. So, as mentioned earlier, Dr. Sabrina was unfortunately unable to stay for the Q&A sessions due to her commitment. We sincerely thank her once again for her excellent presentations. So, I'm still pleased to be joined by Dr. Kadafi and Dr. EJ, who will be answering your questions. May I now invite Dr. Kadafi and Dr. EJ to kindly turn on cameras and microphones as we begin the Q&A sessions.
Yeah, maybe for the first, I would like to say that several my slides, maybe I slide that we talk toxin with but my proposed toxic substance in pediatric, not toxin, yeah. So like my cases is carbon monoxide intoxication and alkali caustic intoxication is a toxic substance. Yeah, especially in our cases, it's not toxin but toxic substance. I'm sorry if I slap cite the toxin.
Okay. All right. So thank you, Dr. Kadafi. So I can see some of the questions have been answered, but I'll still read it for those who did not read it yet, or if the panels want to elaborate more. Okay, for Dr. Kadafi, in severe carbon monoxide poisoning requiring intubation, does hyperbaric oxygen therapy reduces the risk of delayed neurological sequelae in the pediatric population? Okay. Dr. Kadafi, you are mute.
Oh, yeah. About the hyperbaric oxygen therapy, especially in pediatric, to prevent delay effect of the neurologic problem, still debatable. Lot of the experts said that there are the effect of the hyperbaric oxygen therapy, but another aspect said that is not significant between the hyperbaric oxygen therapy and normal oxygen therapy. And if we're looking for about the randomized clinical trial, we still not yet conclude that hyperbaric oxygen therapy make the decision to prevent of the delay neurologic impairment in the next after the patient observed in the several times, especially in my case. Actually, in our center we not yet have the hyperbaric oxygen therapy, so we try in the standard therapy because the patient fall the respiratory failure, so we decide to intubate this patient. We know in our patient have the high risk to the neurologic impairment. Maybe the effects not appear today, but in the next time we can got the sequel of the neurologic impairment. Until now, patient still control in our clinic to observe the side effect of the poisoning, like that.
Okay, thank you, Dr. Kadafi. And I would like to send this question to Dr. EJ. You emphasize that we should treat the patient, not the laboratory results. In your experience, what is the clinical scenario have been the most challenging where acting without confirmatory toxicology tests carried significant uncertainty? And how did you balance the risk of overtreatment versus delayed treatment?
Okay, actually, this is the thesis of the entire lecture. However, it's actually a reality that we really need to face. No, the uncertainty, since we do not have the diagnostic immediately at the emergency room, but the problem of overtreatment, and from that of the risk of delaying the treatment. My approach, though I guess many of us would actually be challenged with, is to balancing the risk of treatment against the risk of not treating the patient. Now, I always rely on the toxidrobinsing and the antidote or I would rather initiate treatment early and continuously assess. That's why serial monitoring is very important. And we need to emphasize that despite us in the emergency room being so very busy, and with a constant influx of patient. Okay, so just like in any medical cases and probably in surgical and traumatic cases, monitoring should be done to, of course, establish the trend. So that is relying on toxidrome and seeing if it has actually available or acceptable safety profile, and then continuously reassessing the patient. Then if the laboratory is available and the results may come in. So it's actually very dynamic. So we integrate the history, epidemiologic context, our constant PEs and assessments, and if the bedside investigations comes in and the patient responds to our therapy. Okay, so that's exactly why I emphasize treat the patient, not the laboratory results, because laboratory confirmation is actually invaluable when it is available, but it should only complement, not replace our clinical judgment.
Okay, thank you so much, Dr. EJ. So next, question for Dr. Gaddafi. I think I changed the question a bit. Is there any toxic agents that is particularly dangerous to children, but not as much as in adults?
The toxic agents is much in children in our country, lot caused by the botulinum toxins that we still got the patient with the clinical finding with the diarrhea in the patient. And the other toxin might be the biological toxin like the snake bite, and because in Indonesia still difficult to treat the biological toxin. We have the one consultant, the biological toxins, Dr. Maharani, and so we always communicate with the Dr. Maharani if we got the a problem, the biological toxin, and maybe yeah, the common problem toxins in pediatric with the clinical finding is diarrhea is come from the botulinum. But if we compare the toxic agents, another toxic agent, we got several cases like in Indonesia have the a traditional leaf, yeah, like the kecubung is make the toxic substance to make the intoxication, especially in adolescents, because they would like to expressions make the uh, one group and together consumption of the alcohol and kecubung, like the traditional substance, yeah, and the others is accidental, like my cases in sometimes the caustic soda, sometimes the alcohol, and a lot of the other substance like that.
Okay, thank you, Dr. Kadafi. So next is for Dr. EJ. How important is analytical toxicology in current situation in Southeast Asia countries? What are the immediate hurdles that need to be lifted to improve current limitations? Dr. EJ?
Actually, it is very important, but across regions, no? In Southeast Asia, especially in Southeast Asian region, this is actually one of the challenge because majority, if not many of our hospitals or our institutions are actually resource limited. So we cannot emphasize or we cannot overemphasize that analytical toxicology is actually fundamental in improving patient care, not just clinical management, public health as well, as it confirms exposure. It identifies probably emerging or re-emerging toxins. As you can see, there are a lot of re-emerging toxins. And lastly, if you were able to see or if you will remember the dimple, it actually supports surveillance through research and educations, and it will guide policy. However, clinical management should never be delayed while awaiting laboratory or diagnostic confirmation. So I guess in my humble opinion, the priorities are actually expanding access to analytical laboratories. If when I say expanding access to analytical laboratories, know what is your trend, know what toxins or substance needs to be addressed in your own locality, because these are actually area specific and geographically, they must be geographically appropriate. And then you need to standardize these testing methods. And if you're not able to do that, you need to strengthen, or one needs to strengthen the regional laboratory networks that we have. That's why we have networking. Okay, and then of course, though funding is really very difficult to achieve, we need to ensure sustainable funding, and we have a lot, or a long way to go when it comes to sustainable funding, especially when it comes to public health funding. And probably while doing that, we can train more specialists, not only clinical toxicologists. We can actually train our partners as well, like nurses. You have your pharmacist, no, you have your medical technicians as well, and of course, further strengthen the collaboration between clinicians, laboratory personnel, poison centers, and I guess the public health agencies is key. So it's nonetheless not different with any other health issues or public health issues. We just need to take a moment and realize that, hey, maybe we need to focus or give attention as well to analytical toxicology as much as we are giving, like the infectious or vaccination issues in public health as well.
Okay, thank you, Dr. EJ. So next question to
And should I go on with the next?
sorry, Dr. EJ, there's a
So
problem with
here,
your internet.
yeah, yes. Sorry. So I'll just answer already. I will just give a bit differentiation perhaps on analytical toxicology and analytical
Yeah, you
toxinology.
can
So
continue.
there, yeah. I'm reading the questions already. So for those of you, they are actually closely related, but still, should I say, distinct. So when we say toxicology, analytical toxicology, it focused on detecting and measuring drugs, chemicals, and poisons. So what are those poisons? So if we're going to define it technically, these are pharmaceuticals. You have pesticides, you have alcohols and heavy metals in a biological or environmental sample. So biological samples are us, or perhaps environmental samples could be the rivers, no? So that is analytical toxicology. On the other hand, when we talk about analytical toxinology, there specifically deals with toxins. Okay, so toxins are not necessarily poisons. Okay, so toxins are produced only by living organisms. So just no. So what are those examples? The commonest would be snake bite or snake toxins or snake venoms. We call it venoms. No, scorpion toxins. You have your jellyfish, your marine toxin, your mollusks, and even plant toxins. So those are with specifically to analytical toxinology, but actually rely on the similar machines, the advanced technique that, such as the LCMS or the immunoassays. So they often share one equipment perhaps, or laboratory infrastructure and expertise, although their applications differ. So that's how briefly we can differentiate and differentiate analytical toxicology and analytical toxinology.
Okay, I'll save the last question for later. Okay, next question is for Dr. Kadafi. A tangential question. I think this is more to medical legal questions. In Dr. Taufiq, the second case study was the child referred to child neglect team Who was the child primary caregiver in securing procedure consent given the mother's psychiatric history? And what was the child's final disposition since he is already in an orphanage?
Yeah, we suspected because the large number of children living in the orphanage, so sometimes the supervision come from the caregiver was not optimal. So this might have allowed the children to gain easy access to the toxic substance like the caustic soda. And according to my question to the caregiver, why this condition can occurs in your orphanage, they say that because a lot of the children in the orphanage and the caregiver is only the small number, so it can make the situation more high risk to the children can reach a lot of the substance surrounding the orphanage. So I think it is a big problem in our country that we have a lot of the people, and maybe it is have to give the more attention to our government to observe the a lot of orphanage. How about the safety children in the orphanage? And about the informed consent, yeah, we face the social problem during the treat in this patient because in the early we treat this patient, we not yet got the direct family to give the education, but after several days we always give the education for the caregiver, and we got the contact with the father, and father delegate with the uncle to make all a decision after communication with the father. So to do the procedure like the ballooning the letter, like planning to surgical procedure, we got the informed consent come from father, child by the uncle, because uh, the limited conditions, so we have to uh, make the informed consent to the uncle, like that.
Okay, thank you, Dr. Kadafi. So I think for this last question, I will share with both panelists. So start with Dr. J. What other avenues you foresee will be needed to practically improve practice in this topic beyond just talks? Can you hear? Hello, Dr. EJ?
Come again. I was trying to look for that question.
Oh, okay, got it.
Or I think I was able to answer it, but yeah, wait. Here. Right. I think I was able to see this one. Okay. So here, what other avenues you foresee will be needed to practically improve practice in the topic just beyond talks? Now, actually talking here, what we're doing, lecturing and sharing our knowledge or providing education or exchanging knowledge is actually the first step. There are a lot of things that we can do, but we cannot do it alone. So we need sustainability. Of course, sustainability does not only requires action, commitment, and passion. It requires money as well. So we need sustainable regional collaboration, standardized referral pathways. If you will see in Ramatimodi Poison Center in Thailand, they have actually a very good published referral pathways when it comes to different poisonings. Also here in the Philippines, we have what we call a black book. Let me just see. Yeah, like this one. It's an algorithm, no, but there are just differences. However, as in the Southeast Asian region, we might need to do a standardized referral pathways, if not across region, maybe in your own country, if you have, especially so that we are dealing now, or we are more trying to achieve universal health care, and perhaps you don't need to be trained to that you can actually establish what are the common cases that you encounter, and with that you can actually see what are the things that needs to be requested, and with that you can actually do antidotal stacking. So you see, it's actually more area specific, and it is very cost effective because what you're going to procure and request will always answer those that you really encounter in your own areas. Of course, we cannot discount the importance of accessible analytical testing if it's available. Again, we have this lecture because majority of us do not have that capacity, but hey, working. You can also start multi across your hospitals together with the poison centers. And yeah, us in examples, drug testing is not available here immediately in the emergency department, but it's actually available in outside laboratories. However, it's just available from office hours and during Mondays to Fridays. So what if the patient comes in during Saturdays and Sundays or in weekends or during your graveyard shift? So you can always do some agreement, MOU or MOA, and even policies at that. So there are so many things that we can do, no, this beginning with education and of course the poison registered outcome.
Okay, thank you, Dr. EJ. Dr. EJ still with us? It's okay. I think we can continue with the next question to Dr. Kadafi. I think I pick another two questions. One is, would treatment using unproven therapy be ethically permissible in situation where uncertainty in diagnosis or toxic manifestation due to lack of resources? Any place for the traditional method for this instance?
Yeah, it is still a classic problem in our country, because yeah, we come back to our title presentations, that my thesis is about the clinical clinical approach pediatric positioning, because there are one maybe there are one the principle in our limited resources, like in our hospital, that if we not treat the patient immediately, maybe there are the worsening condition and the result the patient pass away or day. Sometimes if the laboratory confirm is not available, we use the general principle like stabilize patient, and we come back to the history, taxodrome, supportive treatment, and if there are any antidote, we can give the treatment in this patient. And we try to treat the patient based by the uh, history thinking. We can conclude that maybe the substance like that. If we have to looking for the laboratory, we have to send to the maybe Jakarta, we have to send to the maybe the Surabaya and another. We have to waiting times very long. But in other sites, we have to help the patient. So in the some literature, we can use the taxodrome based by the characteristic signs of the positioning, and we come back to the other basic like the epidemiological clue, historical clue. So we according to my opinions, if we stay in the institution or in the center that we have the limited resources, so we can use the clinically and epidemiological clue and taxodrome to help me to treat this patient. Maybe if we compare the ethical and the standard, it's not standard, but if we not treat the patient, or we help not help the patient, so delay the treatment can make the worsening condition. And after we treat my cases, two cases, it is a if we make the match based by the clinical and the theoretically, there are the similar theoretically. So I think it is can make the base to treat the patient. Like that.
Yeah, okay. Thank you, Dr. Kadafi. So there's a technical problem with Dr. AJ, but huge appreciation to our panelists for their time and efforts. I think let's give our speakers a virtual round of applause for sharing their expertise and valuable perspectives for us today. Now it's time for the exciting part of the seminar, which is our Kahoot sessions, featuring the questions based on today's presentation, and we will begin shortly. I'm sorry, Dr. AJ, thank you so much. Thank you so much for your time and effort. I think we will end this Q&A session for now, and we proceed with the Kahoot session. Thank you so much, doctors.
Thank you.
Thank you, everyone.
Thank you, doctor. So for everyone to participate, please have your mobile phones or devices ready. We will now display the Kahoot pin and QR codes on the screen. Simply scan the QR codes or visit kahoot.it, enter the game pin and type in your name before joining the quiz. Net vision, saya, and OK. So congratulations to winners. Please screenshot your screen and text us to the number that we will share in the chat box so that we can guide you for the prizes. So to everyone else who participated, thank you for joining in and making the session lively and enjoyable. I hope everyone enjoyed the quiz. Okay. Once again, on behalf of the organizing committee, we sincerely thank all of our distinguished speakers for your time, your expertise, and your generous contribution to today's seminar. It has truly been an honor to have all of you with us. Thank you generously for sharing your knowledge and experience. I would also like to thank all of our participants for your active participation throughout today's seminar. We hope you found the session beneficial and that you'll be able to apply what you've learned in your own clinical practice. Oh, I can see Dr. EJ is still with us. Before we conclude, can I have Dr. EJ I'd like to take this opportunity to invite each of our speakers to share a brief closing message, one key takeaway for our participant today, perhaps just 1 minute of most important message you would like everyone to remember from today's seminar. You may start, Dr. EJ.
Okay, so thank you again for the opportunity, and I hope that we will be having multiple sessions like this. We have of our organizers to please follow through on each week as we offer other topics as well that is very pertinent for us who are always frontliners. Now, actually, there are just few things that I'd like to share and of course emphasize. Please treat the patient, not the poison. And perhaps what I've mentioned in the answer that I was able to give to a certain question a while ago is that being a resource limited institutions or hospitals, as we all are here, share the same experiences across the region of Southeast Asia should never lower our standards of evidence by it either be when it comes to testing, patient care, and especially so when intervening or just like administering antidotal therapy to a patient. So this actually just reinforced our clinical judgment. Okay, so you guys are the most important laboratory tests being around in your own areas with your patients. So diagnostics, laboratory functions are equally important and they complement our management, but your knowledge and your prompt action will always determine the patient outcome. Thank you so much.
Thank you so much, Dr. EJ. Your contribution has truly made this seminar very informative and very inspiring as well. Thank you so much. So, bye-bye, Doctor. Our sincere appreciation also goes to our organizers, co-organizers, collaborators, sponsors, and entire organization committee for their hard work in making today's seminar a success. Please don't forget to complete the attendance and feedback form if you haven't already. Your feedback is really appreciated and will help us improve future programs. We will share the QR code after this. Stay safe, keep learning, and we look forward to seeing you at our next emergency medicine seminar series next week. Have a wonderful day, and everyone, and goodbye.